organized by ESNO, European Society for Specialist Nurses, European Specialist Nurses Organization. This webinar will be about CAUTI, so that will be about urinary tract infections caused by catheters. I welcome you all to this webinar again, which will be supported by Hartman. That's an organization which sponsored this webinar financially and made it possible. The webinar will be done by a few of our colleagues. Noel Abela is one of the colleagues, Eva Wallace and Laura Ross, and they will all give a presentation on this webinar about the different subjects about CAUTI. Please, Noel, the stage is yours. Start your presentation.
Thanks, Janet. I welcome everybody for this webinar. And the first part of this webinar, I'm going to speak about some facts and figures about CAUTI. If we look at the USA, right, UTIs are the most common hospital-acquired infections. In fact, 80% of these are due to an indwelling catheter. And also, an indwelling catheter carries a daily risk of CAUTI acquisition of 3 to 7%. 12 to 16% of adult inpatients will have a catheter during their stay as well. And the National Health Safety Network, in 2011, the CAUTI rates for adult inpatients were between 0.2 and 4.8 per 1,000 catheter days. We also know that catheter-associated urinary tract infection is reported to be the most common healthcare-associated infection worldwide. And also, it is estimated that 69% of CAUTI events are avoidable. Also, CAUTIs lead to longer length of stay of hospital stays in healthcare as well. And also, it is the leading cause of secondary bloodstream infection or bacteremia. And also, we have that using antibiotics to treat UTIs without symptoms, unfortunately, would contribute to more the problem of antimicrobial resistance. Also, there are studies that have found a strong correlation between catheter use greater than 6 days and also the development of CAUTI. When we speak about mortality rate, it decreases to approximately 10% when the patient also has a secondary bacteremia, which means a bloodstream infection as a result of the UTI. Also, CAUTI is the most common adverse event associated with indwelling urinary catheter use. Now, what we know about the European countries, this is a slide by the ECDC, and every 5 years, the ECDC, they do a point prevalence study, which is quite a robust study. And here we're seeing that, first of all, 6.5%, the healthcare-associated infections accounts for 6.5% approximately across Europe. Although CAUTI is not common as in the US, but still, as you can see in this slide, it's one of the top 3 when it comes to healthcare-associated infections. And also, from the same slide, almost half of all UTIs are in urology wards, as you can see. And 71% are CAUTI, which is very similar to the US. In 2007, Ireland, they did a study on healthcare-associated infections and antimicrobial use in long-term care facilities. And the survey looked at the following: healthcare-associated infection, antibiotic use, infection prevention and control resources and practices, and antibiotic resistance. What is interesting that from this HALT study, healthcare-associated infection in residents with a urinary catheter was double compared with residents without a catheter. Also, residents with a urinary catheter had 14.1% antimicrobial use, and 17.3% of all these had a healthcare-associated infection. The whole study, 2016 analysis, showed that urinary catheter use to be the only significant risk factor for both antimicrobial use and healthcare-associated infections. And here we're seeing urinary catheter use in the European Union countries and even in the EEA countries. And we have a wide variation here. It starts from a 5%, next please, a 5%, and goes up to 35%. And this shows, as I said, a wide variation, beginning from Lithuania, which is the least, 5%, and the most being used, urinary catheter use, is Greece, followed by Cyprus, Italy, and the Czech Republic. And now I would like to pass the floor to my colleague, Laura Ross. Before I end up, this is very important, but because in 1958, although it's a bit old, Dr. Paul Beeson warned that the decision to use this instrument should be made with the knowledge that involves the risk of producing a serious disease, which is often difficult to treat. And I think I have to say that this advice remains relevant today. And excuse me, I will pass the floor now to Laura Ross.
Thank you very much, Noel. I would like to explain, the guidelines. The guidelines today, as we know, official guidelines shows us the evidence and are adopted by some many organizations, as you know, the WHO and also CDC and also Joint Action, and why not, European Association of Urinary, and also the urinary for nurses. So it shows that the CAUTI, it's important, then we should have to manage it and make it as a proper way, okay? Trying to make a prevention and make a reduction of these procedures. The evidence shows recommendations, but maybe they are not sufficient because it's, as you can see, are not followed for all the European Union. No, so we have to improve it. We have to improve the knowledge, and also we should have to make it in a universal way. Why? Because not all the critical units are the most users of the catheters. No, maybe we can see this also in emergency units and in a parts of the world. No, the important thing is we should have to know what's the damage of all of this. No, 7 billion economic damages are made by year. Also, hundreds of euros. It's the cost of the CAUTI, which is estimated between 700 and 800 euros, no, per day. And also, we should have to know that the extra days of the patient in a hospital will be between 5 and 40. So at the end, we should have to reduce the antibiotic use. We have to increase the patient safety, trying to reduce these CAUTI procedures, okay? So how we can do this? We can prepare and make a proper use of urinary catheterization, a proper insertion of this, a proper maintenance of this urinary catheterization, trying to guarantee the quality of the care and going further to understand what we don't have to do. The most important thing, we should have to make it is in a proper way. We should have to make it as an aseptic technique using sterile material. Well, do it by a trained and qualified persons. It's a recommendation that maybe 2 persons have to be prepared to make this, nurse and a technique for this procedure. We also think, and it's very clear for all the organizations that we explained before, the hand hygiene is crucial. Okay, so recommendation 1B, and as you can see, all the colonia of bacteria and all the microorganisms that we can see in our hands are directly linked to these infections. Okay, who make these recommendations now, before and after the insertion? But we have to go deeply on it. We should have to introduce these hand hygienes in the proper moment. Okay, so we will see this in deep. Okay, why? Because at the end, our flora, our microorganisms, what we have in our hands as a staff, can do pain to the patients. Okay, at the end, they are not the same. The germs that we have, it's not the same that the germs that the patient have. So we should have to be careful with it. Okay, the insertion of the catheter have to be make it in appropriate indications. There are some literature that explains it in deep. Okay, we have to minimize the urinary catheterization duration, okay, particularly in persons who have a higher risk of CAUTI or mortality. Also, we don't have to use these urinary catheterizations to manage the incontinence. It's crucial, okay? And also in operative areas, we should have to reduce the use of catheterization as much as possible. It's only, we should have to use it only when it's necessary. And also, we should have to know that the removal of the catheter should have to be done as soon as possible. Okay, we are going deeply in the protocol. This is the patient hygiene. If the patient have is autonomous, they can do it by themselves. But if we have to do it in our site, we should have to use a water and soap and sterile swabs to make it, okay, placing the patient in a waterproof underpad. The antiseptic, the patient hygiene, okay, the antiseptic, the antisepsis part, it's recommended to use a kit or a set to make it in a proper way, in a septic technique. It's important, and we should have to unfold all the material in a proper way, trying to not contaminate the materials. Putting the gloves, we can place these fenestrate drapes to the patient, trying to be very careful with a special attention with the surroundings, trying to not infect the procedure, and disinfect the area, leaving the antiseptic the time recommended by the provider. It's very important. If we don't make it in this way, and we want to use directly our hands to the mucosa in the area, we should have to change the gloves again and make a hand hygiene, okay? The selection of the diameter is very important. It's crucial. The size, the length of this it's important to guarantee the right procedure. Okay, as small as possible is the recommendation. The silicone catheters also are recommended, trying to avoid this risk of incrustations and minimize the allergenic reactions. We have to have an attention to the balloon filling in terms of volume and solution. It's important that we should have to follow the provider recommendations, check this correct inflection, and use always drainage bag with anti-reflux system. It's important to prevent the reflux of contaminated urine. And also a sample collection port. It's something that can guarantee the no manipulating of this connection, and also can give us the correct and the secure use of this device. Always we have to use a sterile and single-use lubricant in order to facilitate this catheterization. We should have to make it properly, trying to introduce it between 6 and 8 centimeters, infling the trying to introduce in the balloon unsterile water. The saline solution, it's not recommendation for the crystallization of it. If we cannot see the signs of urine flow, maybe there is an anatomic error. We don't have to go back, okay, because it can increase this damage, and we can perform some errors in the process. Please avoid the collection tube bending. Secure a catheter to the patient. It's important because we can reduce these trauma issues that can occur, and place the bag in the patient's bladder level. Okay, it guarantees that the flows it's in a proper way without touching the back to the groove. Disinfect the hands is the last part. We should have to disinfect our hands, and we should have to introduce all the record in the nursing history of the patient, the type of catheter, the insertion, the recommendations, and all have to be scheduled. The adherence to the recommendation requires time, requires attention, and requires also follow-up for the staff. And this is something in many cases difficult. In this way, we can see the barriers detected in a study, make it in a 12 de Octubre hospital in Spain, that shows these barriers. No, asking directly to the staff, they speak about the lack of trainings, the awareness of the doctors and nursing staff. The nursing staff work overload and turn around. They don't have the appropriate infrastructure and the awareness of the catheter experience. So the recommendation is very clear. The protocols must be reviewed and uploaded in an easy way almost every 3 years. We should have to use a checklist. We have to reduce the missings, because at the end can do this pain to this procedure, and use a kit of a set to offer this standardization needed and required. And also regular feedback to the staff. It's important. At the end, we should have to make a plan. To make it essential to follow the recommendations mentioned, we should have to make a status quo, design a solution, implemented monitoring. It gives us the higher quality to the patient, satisfaction to the staff, and also reduction of cost and improved efficiency. Last but not least, I would like to explain you a little bit that we may perform on a study in a hospital, Beach Hospital, with this multimodal strategy and standardization. And it can give us the results about the increase of the hand hygiene adherence, and also the guarantee of the technique it's performed in a proper way. And then also I would like to make a remark to our Florence Nightingale, that she says that I never gave or took an excuse. Please do it too. Thank you very much.
Well, thank you, Laura, for this excellent presentation. For the audience, it is possible to put in questions in the Q&A box, and they will be answered at the end of the 3 lectures which will be given. So please put in your questions if you have any, and we will answer them at the end. The next presentation will be done by Eva Wallace, and she will be presenting something about problems which will be caused by catheters and complications and the maintenance of catheters. Eva, the audience, the podium is yours.
Thanks very much, Janice, and welcome to everybody, and thank you for listening to me. The objective of this short session really is to actually just to give you an idea of the problems that might occur. First of all, we need to clarify the need for catheterization. We need to be able to understand the knowledge and skills and the practical aspects of catheterization In order to be able to reduce the likelihood of CAUTI and infections, we also want our patients to be compliant. We've already discussed the guidelines, and these are just more, so we'll just pass on those. Catheter complications, there are many, at least one per person in a 12-month period. You can have CAUTI, blockages, accidental dislodgement, sediment, leakage bypassing, bladder spasms, kinks, twists, catheter pain. The list is endless. I'll just address a few of them today. As I see it, the most important thing is to understand anatomy. That's really essential. Many of us forget the length of the urethra varies and that catheters come in different lengths. There are different problems around male, female, and indeed changing a suprapubic catheter. The male urethra poses many different challenges, and as you can see from the diagram here in the middle, that there are up to 5 different areas that there could be problems when you're inserting the catheter. For the female, picture on the left, sometimes the most difficult area really can be to locate the urethra. However, when it comes to the suprapubic, it's kind of a blind procedure. You don't really know, and if you're doing it in a neurogenic patient, the bladder can be quite contracted, and knowing the length of the suprapubic can be difficult. There are 3 catheter-associated entry points for bacteria. You have the urethral meatus, the junction of the catheter bag connection, and the drainage port bag collection. Infection can get in extraluminal, and that can occur 66% at insertion with an incorrect technique or at any time during manipulation. Intraluminal, 34% of the infections can occur, and that's during a break in the closed drainage system. It can be a faulty technique, collecting a urine specimen, or disconnection, or maybe when people are emptying the bags. We also need to remember that patients can self-infect themselves from the perineum maybe, or there can be cross-infection from the staph examiners. Causes of break in sterility, you can get contamination of the sterile field, can occur even before the insertion of the catheter. This can be caused by touching items on the sterile field with your bare, non-sterile hands, parts of the body, garments, stethoscope. Contamination of a catheter can occur at the meatus if the catheter tip touches the genitalia before being introduced into the urethra. And you can have a breach of the sterile barrier can occur when a person inserting the catheter uses the same hand with sterile gloves to swab the genitalia and then the same hand to insert the catheter. This slide is really interesting. If you look at the light blue, not at all confident, the red colour, not so confident, and the green, somewhat confident, a little bit frightening. When you add these up together, you can see 75% of people are somewhat confident changing a suprapubic catheter. If you look at the female catheter, you can have up to 46% aren't that confident. Imagine less than 50% passing female catheter. For the male catheterization, 34%, and overall catheterization is 30%, not so confident. I suppose if you looked at it the other way, 70% of people are confident passing overall catheters.
Maintaining ANTT holds the new catheter with sterile forceps, slowly introducing the catheter into the bladder via the suprapubic channel at the observed length and angle of the catheter removed. Observe for urine drainage, and then advance the catheter a further 2 to 3 centimeters to ensure it is in the bladder. Avoid dislodgement of catheter while slowly inflating the balloon. Once inflated, rotate gently to ensure free movement of catheter and bladder. Attach the catheter to a drainage bag system using ANTT. Clean and dry the suprapubic catheter site. Support the catheter and drainage system with a catheter fixation device to minimize the risk of trauma.
We've just shown you a short clip there. You can click onto the www.nrh.ie/healthcare/resources if you want to see the full video. As you all know, the link system or the closed drainage system, it's a one-way flow of urine from bladder and there should be no breaks in the system. It is universally accepted and important in the reduction of CAUTI. The bed bath, I don't think that gets enough attention. Needless to say, you should wear gloves before any catheter manipulation. The drainage bag should be checked frequently, 2 to 4 hourly. When empty, 2/3 full, as the flow can be restricted if it's overfull. Always empty urine bag before transport or movement. Avoid long tubing with loops or kinks. Consider attaching the bag near the end of the bed to prevent the kinking, and this will promote unrestricted urine flow and aid gravity. Drainage bags should always be kept lower than the bladder. Doesn't matter whether you're lying, sitting or standing. Remember, the urothelium can get sucked into the eyelets of the catheter, causing trauma and preventing the flow of urine. They say the urine bag shouldn't be lifted 30 centimeters above the bladder. Use a suitable catheter holder and never ever place the catheter bag on the ground. Leg bags and leg ties are very important as well. They come in many different shapes and sizes. The direct inlet tube comes in various lengths from 0 to 38, and these should be adjusted for each individual depending on patient's preference. A belly bag is also available and can be suitable for suprapubic drainage, especially for those with dexterity issues. Bags must be secured adequately to avoid any trauma, and the urethra should be secured with ties or a sleeve. Remember, patients can be taught to empty their own bags. The electric bag emptier can be recommended for individuals with reduced dexterity. Catheter securement devices are a must to prevent urethral trauma and are necessary to stabilize and anchor the catheter to prevent adverse events such as tissue necrosis and infection. DeRouche in 2016 stated there was a significant 45% reduction in the rate of urinary tract infections on patients with a securing device. There are many adverse effects really, and I suppose blockages are what we all know. Urethral injuries can be quite difficult, but it's interesting to know that morbidity and mortality are greatly affected by catheters. We oftentimes forget about the psychological and sexual issues, and these could have a feeling of negative body image and reduce sexual self-esteem. Bladder cancer and bladder calculi are also a problem. We must understand if there's difficulty in urinary catheterization, so you should always, before going to a patient, check, is there a history of difficult insertion? Does the patient have an enlarged prostate? Are there strictures, false passages? What we say is stop if there's any resistance felt when you're inserting the catheter. If you continue doing repeated and unsuccessful attempts at catheterization, you're increasing the risk of CAUTI, morbidity, mortality, sepsis. Catheterization can induce stress and pain. You can also get catheter balloon injuries, false passages, etc. If we look at catheter balloon injuries, it's something that people forget about, and that's where the catheter balloon is blown up in the urethra. A recent study has shown the incidence of traumatic urinary catheters were 13.4 per 1,000 catheters in male patients. There were 8 mortalities, one of which was due to severe urosepsis resulting from catheter balloon inflation in the urethra. The picture here, you can just see a suprapubic catheter, and you can see the tip of the catheter in the male urethra. If the bladder gets blown up there, it will cause a lot of urethral trauma. The second picture on the right, the axial CT, it shows a catheter in the bladder, but the balloon is blown up in the prostatic urethra. Of course, this can be avoided if you use the transurethral catheter safety system, which prevents these injuries occurring. Overgranulation of the suprapubic catheter is where you can get proud tissue of the wound, and it can be difficult to look after, but you need to be aware of it, as it's another area that infection can occur. We can take the purple bag syndrome, and all of these organisms are prone to it. And if you see that, really it's important to maybe just change the catheter. Sometimes They don't always need to be treated on antibiotics, depending on their stage and their temperature, or if they have any other symptoms.
This short video highlights features of long-term catheterization not normally seen by the clinician. After 3 months catheterization, the bladder will inevitably be colonized by bacteria. And apart from trauma, infection accounts for all the complications that may arise. A flexible cystoscope has been passed through the urethra. With the end held at the neck of the bladder, the tip and balloon of the suprapubic catheter are clearly visible. Inflammatory debris can be seen floating freely around in the urine, producing an effect rather like a snowstorm. As the bladder empties, the urothelial lining of the bladder wraps around the catheter. This view of the catheter tip shows the inflamed edematous mucosa, the biofilm on the surface of the catheter, and debris in the bladder base. Note how the mucosa is being sucked into the eye holes of the catheter, forming pseudopolyps, which can obstruct the lumen of the catheter. This arises from the negative pressure which develops in the drainage tubing from the unbroken column of urine above the urine collection bag. If the vertical height between the bladder and bag is 30 centimeters or more, the suction effect can be dramatic. Watch as the bladder empties and note how the mucosa is suddenly sucked into the eye holes. And then, on refilling, the bladder has to become quite distended before the vacuum is overcome and the mucosa is released. When a catheter repeatedly blocks, cystoscopy.
Thank you for that to Noel. If you need to see the full video, it goes on, it's 5 minutes long and it's actually worth looking at. What they're saying there is if this repeatedly occurs, you need to go for a cystoscopy and have further investigations done. So in order to reduce infection, as Laura was saying, you should always select the smallest size catheter, use aseptic non-touch technique. It's important to use adequate sterile lubricant gel to minimize urethral trauma and to reduce infection. It's good always to have a checklist in place for patients for discharge or for admission. And the use of care bundles is really important. If you can monitor your care at local level by using care bundles, it's very good. I really think there should be a routine in place to empty the drainage bag. We should be able to secure and position bags appropriately. And what's most important is education. And I think that's where we fall down. It's not just enough to educate the nurses, the doctors, the healthcare workers. I think we must also educate the patients and carers. I know a lot of time patients would empty their own leg bags and that themselves, so it's really important if they connect or disconnect, if family members or whoever's looking after a patient with a catheter, that they also get educated. I suppose the CAUTI is the most common infection in hospitals and nursing homes. And really, C, catheterize only when necessary. A, remember to use aseptic insertion technique. U, that's you personally, not the doctor. Whoever is looking after the patient must review the need for the catheter. Does it really need to be there? T, training for all healthcare workers, patients and carers alike. If we do all that, infections would be reduced. And as we say, no catheter, no CAUTI. So providing evidence-based care is really the most important for all of us, and we should all work to local guidelines. Just a list of references there if anybody wants them. Thank you now, and I'll pass you over to Noel.
Thank you, Eva, for this excellent presentation about complications and maintenance of catheters. Noel will start with the last presentation of this evening. It's about hand hygiene, which is a very important issue in everything about healthcare, almost everything you do, and especially in CAUTIs. Please put in your questions in the Q&A box if you have them. We will answer them after this last presentation. Noel.
Thank you, Janet, and thank you, Eva, for the nice presentation. I'm going to speak about hand hygiene and also about prevention of these CAUTIs. This slide is showing what is the best product to use for hand hygiene. It is well known that one of the best products is alcohol-based hand rub for various reasons. Amongst them is that the time factor. It takes less time than soap and water, and we know that the biggest hurdle for healthcare workers for not performing hand hygiene is we don't have much time. We don't have enough time. And therefore, alcohol hand rub is the best product, not only because of time, but also it kills bacteria. It kills the microorganism, not like soap and water. Because soap and water, it doesn't kill bacteria. It only flushes the bacteria down the drain. Now, when we speak about hand hygiene and urinary catheter care, there are various steps when hand hygiene is crucial. It's important that we perform hand hygiene. And these are before inserting a urinary catheter, when taking a urine sample from the sample port, when emptying a urine bag, and also because maybe we tend to forget the environment, the role of the environment. That means when touching the environment and then handling the catheter or urine bag. Now, when and how to treat symptomatic CAUTI. The patient must meet the following criteria. These are three. The first one is that the patient had an indwelling catheter that had been in place for more than 2 consecutive days in an inpatient location on the date of event and was either present for any portion of the calendar day on the date of event or removed the day before the date of event. Second, patient has at least one of the following signs or symptoms: fever, which must be more than 38 degrees Celsius, suprapubic tenderness, costovertebral angle pain or tenderness, urinary urgency, urinary frequency, and dysuria, that means painful urination. And the third criteria is patient has a urine culture with no more than 2 species of organisms identified. Because the thing is that if there are 3 or 4 organisms, it would be very difficult even for the lab to identify which bacteria is causing if there is a UTI. And at least one of which is a bacterium of 105 colony-forming units per mil. And this is from the National Healthcare Safety Network. And this is an example. This is a guideline by the National Institute for Health and Care Excellence in the UK. A guideline for when to prescribe antibiotics when a patient has a urinary catheter. I'm not going through it all because of the time, but basically the aim of these guidelines is to decrease inappropriate antimicrobial use, because as you know, we have this antimicrobial resistant problem. We have microorganisms like CRE, VRE, which are being more resistant to antibiotics. Very important that when we have to have a culture, if the patient needs an antibiotic, we have to offer an antibiotic. And obviously, we have to watch out also for adverse effects of antibiotics, because you know we can get diarrhea, we can get nausea, and also Clostridium difficile, which is antibiotic associated as well. And very important that when we get the urine culture results, we have to review the choice of antibiotic, and also we have to change it according to the susceptibility of the results. Okay? Very important as well, these guidelines tell us that considering removing, or if not possible, changing the catheter if it has been in place for more than 7 days. Right? But do not delay antibiotic treatment. Now, what is asymptomatic bacteriuria? First of all, if it's very common in the elderly, which I think it was mentioned already, and this should not be treated because of AMR. However, if there is asymptomatic bacteria in pregnant women, this has to be treated basically because 25% and more of pregnant women will end up of developing symptomatic bacteriuria. And also patients undergoing a urological procedure which is likely to result in urinary tract mucosal bleeding. Example is TUR-BT. Common bacterial causes of UTI, the most common is E. coli, which accounts for 70 to 95% of cases. Then there are other bacteria like Enterobacterialis, Proteus species, Klebsiella, Staphylococcus safricotocus, Enterococcus group B, Streptococcus as well. And in catheterized patients, the most common are Pseudomonas aeruginosa, Staph aureus, and even yeast. Now, what is the advice for patients if they're going to collect the clean urine sample for culture sensitivity? First of all, hand hygiene. If they are males, they have to wash their penis. If they are females, they have to wash their genitals, including between the labia, to make sure that there is no contamination. They have to start to urinate. And what's important, they don't collect the first part, but they collect the mid part. That's why it's called midstream. Screw the lid of the container shut, label the container with full patient details, very important that we check that he is the right patient, and then we end up with hand hygiene. Regarding urine sampling, very important, do not take samples from the urine catheter bags. Eva has highlighted this, that because the urine bag is already contaminated, especially if the catheter has been there for many days. And also avoid taking samples through long-standing indwelling catheters. Ideally, if you're going to take a culture sensitivity, if there is a suspicion of CAUTI, it's better to change the catheter if possible. Now, regarding sampling in catheterized patients, very important to know that bacteria occurs at a rate of 3 to 10% per day of catheterization. And 10 to 25% of these will go on to develop a symptomatic UTI. Very important to note that positive urine culture taken from old catheter does not mean UTI. We have to correlate with the clinical picture, mainly with the signs and symptoms. As I said, ideally change catheter before sampling. And also, although the urine maybe it's cloudy or smelly, this is not indicative of UTI in the absence of other symptoms and signs. Now, this is a video showing how to obtain a urine sample from an indwelling urine catheter. These are the items that you need to collect the sample. Maybe they vary from country to country.
Perform hand hygiene. Verify the patient's identity with the pathology request form and explain what you are going to do to obtain consent. Prepare all your items in a clean tray, checking expiry dates, and bring them to the patient's bedside. Expose the catheter tubing, ensuring that patient's privacy is preserved at all times. If there is no urine present in the drainage tubing, clamp it below the sampling port for 15 to 20 minutes, using a non-toothed clamp. Perform hand hygiene and wear an apron followed by gloves. Open the alcohol-impregnated swab and clean the sampling port on the tubing. Allow to dry for 10 to 30 seconds. Remove the syringe from its packaging using an aseptic non-touch technique. Insert the tip of the syringe into the needle-free sampling port at a 90-degree angle to the tubing and aspirate the required amount of urine. 10 mL are usually sufficient. Withdraw the syringe from the sampling port without contaminating the tip of the syringe. Transfer the urine into the sterile specimen container and replace the lid securely. Dispose of the syringe as appropriate. Clean the catheter port again using an alcohol-impregnated swab. Remove gloves. Perform hand hygiene, then remove the apron and once again perform hand hygiene. Ensure patient privacy is again maintained by covering the patient and perform hand hygiene once again. Affix the label with the patient's details to the specimen container. Place the specimen container in the specimen bag. Insert the pathology request form into a separate bag and send the specimen and request form to the laboratory. Document the procedure in the patient's notes.
Okay, now collection and transport of specimen. Now, very important that specimen collection techniques and transportation are critical. Why? Because if they don't arrive at the laboratory, all right, the sample may arrive soiled, for example, and therefore it can affect the results. Therefore, even the collection technique should ensure that the specimen is not contaminated with colonizing flora, which is ensured through adequate disinfection of the sampling areas we saw in the video. It's ideally collected prior to starting antimicrobial therapy, okay, because antimicrobial therapy may lead to a false negative result. And also important that transportation of the sample is also important, as it has to reassure the viability of the possible pathogen is maintained. But the sample, very important, must reach the lab as soon as possible and be transported in the adequate sampling container. What are the consequences of inadequate sampling? Inadequate sampling may give a false or positive result, which may in turn result in prolonged hospital stay due to delayed or wrong diagnosis, delay in establishing appropriate infection control precautions, which may lead to outbreaks, and even increased costs. And therefore, we have to make sure that when submitting a sample, we check the correct patient details and appropriate clinical details. Just to quote a paper, this is the role of the nurse and prevention of CAUTI. This was about the knowledge, attitude, and practice in relation to CAUTI. It was a cross-sectional study. And what does this paper contribute to the wider global clinical community? There were 3 points. First of all, nurses play a primary role in urinary catheter management and CAUTI prevention, as the insertion and maintenance of urinary catheters come under the scope and standards of nursing practice. Nurses' understanding of and attitude towards CAUTI prevention are considered essential for the safe practice of urinary catheter care. And lastly, education intervention is necessary to improve nurses' knowledge regarding infection control practices and the balance the knowledge and practice gap. Next slide, please. This is called the Houdini. Houdini was one of a famous magician, but basically, is there any hematuria? Is there any obstruction, urology, surgery, decubitus ulcer, input, output, not for resus, comfort care, or immobility? If no, then simple, then make that urinary catheter disappear. Best practices that help prevent CAUTIs. And to sum it up, to recap what I said, this is a wheel, and I thank for the permission from the EAUN in the US. But basically, we have to have an appropriate catheter care. That means indication, alternatives to urinary catheter insertion. We have to have a proper insertion maintenance intervention in terms of insertion, securement, drainage back, and even personal hygiene, and also prompt removal intervention. And very important that you have to involve the families of the patient, and also we have to review for need. We have to ask ourselves, do we need this catheter? And the take-home message, once a catheter is put in place, one must keep 2 important concepts in mind. Keep the catheter system closed in order to postpone the onset of bacteriuria. And secondly, remove the catheter as soon as possible. If the catheter can be removed before bacteria develops, postponement becomes prevention. However, I have to say that the best prevention is not to use a urinary catheter at all. And I thank you for listening. Okay.
Well, thank you very much, Noel, for this also excellent presentation. That means we're now at the end of the presentations of this webinar. We have one comment in the chat box, which you all can see, which is from Kevin Holmes. He has one comment that it's constantly important for nurses to be empowered to remove urine catheters as according to protocols, or if you want, you think you can, the catheter can be removed. This means that you as nurses are always in the position to discuss the length of the stay of the catheter. Thank you for this comment. I think that's very valuable. I want to ask the presenters to put on their cameras because there's another question coming in from Veerle from Belgium, as far as I know. She has one question. What do you think about using tap water for rinsing the bladder? I don't know if it's a common practice in different countries where you come from, but Eva, do you have anything to say about this?
Well, we don't use it here in Ireland, and we would never promote it. We would never put anything that's not sterile into the bladder. I know going back 30 years ago, yes, we did, but not now. We would only use sterile. And you get the containers, the Eurotainers, and that with sterile saline in them or sterile water, but we don't recommend it. But I know different countries have different policies.
Yeah. Is it the same in your country, Noel and Laura?
Yes, I agree with Eva. We don't use tap water, we use only sterile fluids.
Same in my country.
Because it depends even on because tap water you can have even Pseudomonas, for example. You know, it's not for sure. It's not recommended.
No.
Some tap water, if you test them, there could be E. coli in them or that. So you so you just never know.
Yeah, exactly. Yeah, for my country, it's the same procedure, same protocol we take care of. Since there are no further questions in the Q&A box, I want to ask all of you to leave us with the most important message which you want to give the audience from this webinar. Noel, will you start? What is your most important message for the audience?
I would like to continue with my colleague, because Kevin Holmes is a colleague from Malta as well, is my colleague. I think, yes, my message is that nurses are on the front line when it comes to CAUTI. Why? Because they insert the catheter, they remove the catheter, they can perform diagnosis as well, because they are there beside the patient, next to the patient, and I think they can be the advocate for the patient when it comes to CAUTI, and also when it comes to antimicrobial stewardship. When it comes to antibiotics, they can remind the clinician, shall we continue with antibiotics? Shall we remove the catheter? I think we have to, as Kevin, my colleague, said, that we have to empower more nurses to take lead in this CAUTI prevention.
Yeah. Yeah, I'm totally agree with Noel. We have to be improved. We have to ask for these protocols, ask to this knowledge, to these trainings to our managers in the hospitals, because at the end we are very close to be alone, no? In many cases, we should have to ask our organization, our institutes, our hospitals, trying to speed or make this improvement to reduce these CAUTI issues. I think it's the most important thing. Yeah.
I agree. You have to actually empower the nurses more. And I think if you have good nurses and they're empowered, but I also think nurses must work to protocols and they must be able to contribute to the infection. And I think it's all about education. And people forget that patients also need to be educated. There's no point in the nurse doing everything 110% and the family come in and everybody else comes in, they disconnect, reconnect catheters. So I think a lot more education needs to go, but I do think nurses need to be empowered. And I think the problem is they're so stressed, they don't have all the time they need to do all these little extra jobs, but I think it's important.
Yeah.
Yes, it is.
And I think even the COVID pandemic didn't help in this area as well.
Yeah, yeah.
There was a lot of collateral damage because of the COVID pandemic.
Yes,
and one of them is
highlighted it's highlighted a lot. We can see increases in all the countries, I think, no, that the CAUTI increase because the knowledge is very poor in some cases.
I thought the slide I had was very interesting on people's confidence in changing catheters. I think that's really powerful because when you look at that and you see that 75% of people aren't confident changing a suprapubic catheter. I think people don't know about catheter balloon injuries. They don't know how they cause false passages. They don't know how the infections occur. They don't understand about cross-infection. I think it's just so much there.
Yeah, actually, I totally agree with you, Eva, and for all the others. I want to end this webinar now. It's 8 o'clock sharp, so that's very good, and thank you all for these excellent presentations. I think the main message still goes for prevention of CAUTI by removing the catheter as soon as possible. I think that's one of the main messages we can leave behind, next to all the others you've mentioned. For the audience, thank you for listening, and I hope you learned a lot about catheterization and CAUTIs. And please take all the messages in remembrance when you go to work tomorrow again. And I also want to thank Hartman again for making this webinar possible. Thank you all for all these nice presentations, and thank you all for listening. Goodbye.